Hello, my name is Mahek Shah. I'm an assistant professor of medicine in heart failure, cardiac transplant, and pulmonary hypertension at Thomas Jefferson University Hospital in Philadelphia. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program provided by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. Our segment today is going to focus on acute pulmonary embolism and pulmonary hypertension in patients with COVID-19. Please note this presentation was recorded on July 31st, 2020, and the information was up to date as of that time. At the end of my presentation, you will be able to see some additional resources if you want to reach out to me or you want to contact anybody else with questions that you may have from the presentation today. So, like I said, our topic of discussion today is acute pulmonary embolism and pulmonary hypertension. I'll tackle with these topics in two separate parts. First, I will just deal with acute pulmonary embolism accompanying COVID-19 infection. And part of that conversation will be, is it something we see with just sick patients that are admitted with COVID-19, or does the virus itself have a direct correlation with causing or leading to acute pulmonary embolism or thrombus in the pulmonary arteries? Second part of the conversation, we'll talk a little bit about patients with pulmonary arterial hypertension and how they can cope with COVID-19 and some of the data that has come out among that group of patients. I have no disclosures related to our conversation today. As we all know, the SARS-CoV-2 virus, which is responsible for causing COVID-19 infection, gets access to your endothelium through the ACE2 enzyme. It's important to remember that the endothelium is present across the entire body, lungs, the heart, the GI tract, which is also why we know that this virus can get access to multiple different organ systems, causing acute lung injury, causing myocardial injury, causing gastroenteritis, among many other problems. Early on, you started seeing some data that there was something unique about patients infected with COVID-19, particularly among hospitalized patients. And there were some early papers that started raising the red flag on whether patients with COVID-19 in the hospital have an increased propensity for thrombosis and thromboembolic complications. Early data also revealed that there was a coagulopathy that was sort of unique to this population. These patients had elevated D-dimer levels to begin with. There were changes in other PTTs, platelet counts, when you look at their blood tests and when you trend them out into the hospital. Additionally, what we also noted was there was increase in inflammatory markers, particularly interleukin-6 or ferritin, when you looked at patients infected with COVID-19. So there was an early association between these. And we also found that rising D-dimer during the admission actually preceded multi-organ failure and overt DIC, which is disseminated intravascular coagulopathy. Some of the papers were hypothesizing why that is the case. And of course, at the end of the day, patients with COVID-19 in the hospital are sick. Sick patients have an increased risk for pulmonary embolism or even DVTs. And that comes from the fact that they're bedridden, they have fevers, they're septic, they have other organ injury, be it liver or kidneys, they may have underlying lung issues, heart issues, malignancies. So the fact that they're acutely sick, we know puts them at a high risk for acute venothromboembolic complications. But in addition, the inflammatory response and the endotheliopathy that results from COVID-19 and SARS-CoV-2 also may play an additional component which exacerbates this problem. And that's the hypothesis that came out early on. And that's what we're going to focus on today. You also started seeing some of these papers come out. This came out from Italy in March, saying that patients with acute pulmonary COVID-19 pneumonia were diagnosed with massive pulmonary emboli. And initially what began as case reports subsequently was described in a case series format. This is one of our papers that is still under peer review, but we hypothesize, based on the data that is available, that it is a combination of factors in this group. Of course, is the loss of integrity of the endothelium, the inflammatory activation, the multicellular infiltration, subsequent platelet aggregation, fibrin deposition. There may be a role for APLA, which is the antiphospholipid antibody production associated with this virus, some data to show that, which results in small vessel thrombosis and likely increase in pulmonary embolism and even DVT in these patients. And we know that patients who develop these complications are at a higher risk for having organ injury, multi-organ failure, and really worse outcomes. I'll spend a little time focusing on this paper because I think this was one of the better papers on pulmonary embolism accompanying COVID-19 infections. It was from 2 hospitals in France. It was published, I believe, in April of this year. And they looked at 135 consecutive CTPA studies among patients with COVID-19 pneumonia. What they discovered was that 32 of the patients actually had an acute pulmonary embolism, coming to 1 out of 4 patients. 50% of these cases were among patients in the ICU. Half of the patients were diagnosed with a PE at the initial presentation, and the other half actually subsequently during the hospitalization, usually because of clinical deterioration. Also important to remember that the division of how they did CTs for these patients was also 50-50. It was 50% had CTs early on, 50% had later on. So that kind of explains the distribution. RV dysfunction was only seen in 6 of the 32 cases. So it wasn't apparent in most of the cases. And we can't really use it to predict, I think, whether patients would have pulmonary angiopathy or microangiopathy or microthrombosis in these cases either. All subsequent PEs were among patients who were on DVT prophylaxis while inpatient. The mortality was pretty high within this group, really 13%. It's important to realize that the control also had a mortality of 12% in this group. So I think the CTPA was done among a higher risk population. The other thing that was notable when you look at the labs within this group of patients is that the D-dimer among patients who had a PE was significantly higher. You can see the difference, which I marked out here. I think 9,841 was the median level within group among the patients who had a PE. Again, like I said, a lot of these patients were in the ICU, as you see at the bottom, a lot of them on mechanical ventilation. This is another paper that came out in the Blue Journal recently, and this is again a single hospital experience. And the authors looked at CT scans among multiple patients admitted with COVID-19 infection. They found that the proportion of patients with interpretable CTs that had a pulmonary embolism accompanying the infection was 38.5%, so much higher than the previous study. They also use, interestingly, dual energy CT, which can actually give you more tissue characterization and perfusion information, which revealed that perfusion defects were very common. In fact, all 18 patients that they looked for perfusion defects had some kind of perfusion defect. And not all of them had a PE, which also raised the question whether this was microthrombosis, just not visible on your routine PE scans. The authors concluded that physiologic, hematologic, and imaging data shows not only the presence of a hypercoagulable phenotype in severe COVID-19 infection or severe COVID-19 pneumonia, but also markedly impaired pulmonary perfusion, likely caused by pulmonary angiopathy and thrombosis. So that's a hypothesis to a degree. This is our own unpublished data where we looked at patients, and this is 9 patients total, who presented with an infection, COVID-19 pneumonia, subsequently diagnosed with a PE later during the hospitalization. And the one thing that stood out was the D-dimer. The D-dimer trend was most significant and statistically significantly increased at the time of PE diagnosis. So I think it's a tool that you can use to trend and sort of tease out if there's patients that are high risk. Unfortunately, we couldn't find a cutoff where we could get adequate sensitivity or specificity because of the lack of data, sample size. Troponin was another one that seemed to trend with possibly development of PE down the line. And we came up with multiple different predictors, at least based on our analysis of patients across multiple centers within the United States, on what led to diagnosis of this disease. And of course, I think the big the big three that you want to know are patients with unexplained acute worsening respiratory failure, despite the presence of underlying pneumonia, worsening PF ratios, worsening ventilatory requirements, presence of unexplained worsening dead space ventilation. These are people who are they have respiratory acidosis, their PaCO2s are going up, their end tidals are falling. And hemodynamic instability and hypotension was another group. So I think that's another group among the sick ICU patients on ventilators that you want to think of a pulmonary embolism at least if you have one of these three criteria. And of course, this is one of the papers that really made it to national news from May, and it was the Mount Sinai experience, where they showed that use of therapeutic anticoagulation among inpatients was associated with improved survival, particularly more prominent effects when you look at patients in the ICU requiring mechanical ventilation. I think this is also hypothesis generating. It doesn't mean everybody needs anticoagulation, but certainly there's a consistency in the data we've seen so far. So the conclusion is maintain a high suspicion for acute venous thromboembolic events, particularly acute PE, in your differential among patients with COVID-19. More often associated with greater illness severity, particularly among patients in the ICU on a ventilator, because there is a high mortality associated with this group. It was 40% among the 15 patients in our analysis. Survival was 60%. And we cannot use D-dimer alone, unfortunately, because it is elevated at baseline in a lot of these cases. Early use of contrast is critical, and that's something that is a challenge because we know that patients with COVID-19 will have renal failure or a high risk for renal failure. And we want to limit repeat CTs. We want to limit exposure to our staff and other patients. So this is something that maybe needs to get incorporated early on in your ER protocol even. Now, supplemental imaging, I don't think we have any data to suggest that these would help predict development of PE or diagnose it. You could use echocardiography, look for DVTs in these patients, or use only a perfusion scan and avoid the ventilation scan to avoid exposure in some of these group of patients. I can tell you that the data so far suggests that the rate of DVT is a lot less than what has been seen in other sick septic ICU patient analyses. Tells you that maybe there's something more primary pathologic going on in the lungs that predisposes them to a PE. Again, consider early use of therapeutic anticoagulation, particularly when you're suspecting acute pulmonary embolism, balancing the need for a bleeding risk. And we need more data. We need more prospective studies to be able to really show this correlation down the line. Now, I'll spend the last 5 minutes talking about pulmonary arterial hypertension and COVID-19 infection. I sort of separated them because these are two different populations. Pulmonary arterial hypertension, as the listeners may know, is associated with multiple endothelial issues that begins with endothelial dysfunction, intimal proliferation, eventually progresses to smooth muscle hypertrophy within the pulmonary arterioles, also adventitial proliferation, in situ thrombosis, plexiform lesion with fibrin deposition, in addition to everything else. So it's a complicated process that is progressive and leads to increased pulmonary vascular resistance. And as we know, as this disease progresses, people really suffer from right heart failure, which plays a big role in how these patients do. And all the treatment is directed towards decreasing your pulmonary vascular resistance, use of pulmonary vasodilators. Now, over the last 20, 25 years, we've had several drugs and several studies that have looked at different categories of pulmonary hypertension drugs. We have endothelin receptor antagonists like bosentan, abrasentan, macitentan. We have PDE5 inhibitors like sildenafil, tadalafil, cyclic guanylate cyclase stimulators like riociguat, and then prostanoids, be it intravenous, subcutaneous, or now even oral IP receptor agonists such as selexipag. So we have a lot of different drugs to choose from when we're treating these patients. And as you may know, standard of care right now for anybody diagnosed with PAH is dual therapy, combination therapy using a PDE5 inhibitor and an ERA. There were also some early papers of concern because, pulmonary hypertension patients are more at risk for developing severe complications from relatively innocuous infections. And that's something that is a process because these people don't have enough reserve. They already have pre-existing lung disease and a lot of issues. So there was concern of how these patients would do if they had COVID-19 infection. Very early on, we realized, and this came out, a lot of this data also comes from New York, that it was not what we expected. And this is one of the more comprehensive analyses that we have on this group of patients. In late March 2020, when experts from over 32 US PH centers responded to a pulmonary hypertension query, they found only 13 patients with documented COVID-19 infection accompanying PAH. There was only one death in that subgroup. Half the patients were managed as an outpatient. The other half needed hospitalization, and less than a quarter of the patients needed intubation. So one would say that these patients were not as sick as maybe we expected. And there were several hypotheses also that have been raised as to why that may be the case. One, maybe these PAH patients are not getting the infection or not manifesting severe infection because they know how to stay away from other people. They've known how to self-isolate for years because that's a big part of dealing with this disease. Could the presence of pre-existing pulmonary vasculopathy or being on these PAH medications that also have additional anti-proliferative and anti-thrombotic efficacy, is that combination providing some protective benefit against this infection? Some of the data also suggests that some of these agents may also counteract endothelin-mediated inflammation, particularly the endothelin receptor antagonist. And does that have a role to play? And eventually, there is a question whether their vasculature, which is already remodeled, is exhausted to manifest severe endothelitis that is required to have severe COVID-19 infection. And they just cannot launch the cytokine release syndrome, which seems to be responsible for worse outcomes within this group of patients. Let me remind you, all of this is hypothetical, but so far, luckily, patients with PAH have not been reported to have much worse outcomes than other patients infected with COVID-19 pneumonia. For those who are looking for resources to understand how to deal with questions that come up with dealing with this group, I would direct you to the Pulmonary Hypertension Association website. I put the link right there on the screen. And they will answer several questions related to the day-to-day of what they should do. Can they go back to work? How should they limit their exposure if somebody in the family is exposed at their job? And it gives you really good resources and responses to deal with this problem. And of course, at the end of the day, for patients who may be listening to this, this is a great resource for you to read. It's easy to read, and it gives you some very valuable information on dealing with these times when you have pre-existing pulmonary arterial hypertension. So with that, I will end my talk today. Thank you for this opportunity for CVI for letting me come on and talk to you guys. I put my email at jefferson.edu is my first name, last name, my phone number here. And I put my Twitter handle. If you want to find me on Twitter and talk to me there, certainly feel free to reach out. And then, of course, if you have any questions, you can email me directly, or you can email Mark Hartnett, who is the executive director at CVI, on the email attached here. Feel free to share this link if you think the information would be valuable to somebody you know. And thank you for watching this CVI Heartbites segment. For more information on CVI Heartbites segments, as well as other CVI educational programs, please visit at cviphiladelphia.org. And you can follow us on Twitter at CVI Phila. So thank you for this opportunity, and hope you enjoyed the talk.